See in this photo here is this is the peritoneal lining, and these little white dots are called tubercles, or actually would be consistent with tuberculosis. And the biopsy report was noted to be diffuse granulomatous changes. AFP stains still negative. So interestingly enough, she ended up having a repeat T-spot done, and that repeat T-spot was now positive. And I think when that became positive, that ended up being the clue to get infectious disease involved. Before, everybody was just going on with the cancer diagnosis, and this is when we got involved. And when I looked at the case, really the argument for TB seemed pretty clear to me. She had a lymphocytic ascites and pleural effusion. She had enlarged mediastinal lymph nodes. She had non-caseating granulomas. Typically they say they're caseating granulomas, but oftentimes we don't see that. Despite that, the AFB smears were all negative. She now had a positive T-spot test. I failed to mention before, but she had an elevated adenosine deaminase levels on the fluid, which can be consistent. She had low-grade fevers, and then of course she was a high risk because she was immunosuppressed on a TNF inhibitor, which is known to increase the risk of relapse of TB. So at this point, what to do? So I decided to go ahead and start empiric TB therapy. And at that point is when I had a conversation with Dr. McMahon about the case, and we ended up discharging her under the care of Allen County Health Department to continue on with the treatment. So as we all know, AFB cultures take some time, and finally those pleural cultures and ascites cultures from back in December from the prior studies finally came back positive for TB, and this was actually INH and rifampin-sensitive TB. So I think this elevated CA-125 was a red herring, and I think it probably threw people off, and I honestly didn't know what to make of it either. So I actually went and looked, and it's not, it is described that you can have the elevated marker with tuberculous peritonitis. And here are two studies which really look at the incidence of this. So all these papers actually recommend that when you are working up this, to really not do this test because it can be misleading, and it's not just solely a tumor marker. It can be elevated due to numerous reasons, including this. And then I thought it was pretty interesting that this really looked like an ovarian cancer, and whether this had been described, and certainly it has. This is a study from 2006 where they reviewed cases of peritoneal tuberculosis that mimicked ovarian cancer. So we were able to have some patient follow-up. She actually, the patient was admitted in June due to some abdominal pain, which was found to be totally unrelated, but we're able to get some images. So you can see the chest x-ray here. Those pleural effusions are gone on both sides. The chest CT, again, confirms that the pleural effusions are gone. There are no enlarged lymph nodes there anymore. And then on the abdominal CT, you actually do see that very clear marking between the peritoneum and the abdominal wall. So that was my interesting case. Any questions? She got started on a 4-drug regimen off the bat. I had no results at that time. We were able to go back and get some of that fluid sent for MTV PCR, but again, that took about 2 or 3 weeks to come back. So I started that therapy really with the argument that this smells like TB, this looks like TB, I don't have any other diagnosis that could do this, so I'm just going to go ahead and start. And I think that bought us a couple weeks at least of ongoing treatment. And in discussion with Dr. McMahon, that's a pretty common strategy if it seems to be very suspicious. No. It's hard to say. Yeah, I think the gynecology, the gynonc surgeon, I think in her description said miliary in the opno, so I think there's already things moving towards that. But really, the T-spot was why we ended up getting called on the case. And as we all know, we really can't diagnose active tuberculosis based on a PPD or a T-spot. That's not. It can be helpful, but if it's negative, it really doesn't help you at all. She did. She had a T-spot that was negative a year before she started, and when she first presented with the abdominal discomfort, she had one again done then, and that was negative. So between late December and January, she converted positive. Yeah, she denied any known exposure. I'm sure that she was exposed growing up in Bosnia in Eastern Europe. She would definitely be classified as disseminated tuberculosis. So she had pleural pulmonary TB with effusion in her lungs, and then she also had tuberculous peritonitis. So it would be classically called miliary TB. So I think that's how it ended up seeding into her abdomen. Tuberculous peritonitis can develop. That's a common way that it can do that. A second way is that you can have a lymph node inside of the abdomen that was infected during the primary TB, and then it can reactivate. And again, she was older, so that was a risk factor for reactivation, and the biggest risk factor for her was the TNF-alpha inhibitor. Yeah, that's a good question. So when both PPDs and T-spots in the setting of active TB or miliary TB, for example, it is actually pretty common that the body's response to that antigen to have a positive test actually decreases. So you get this thing called anergy, where you really have florid TB, but the test is negative, which is one of the reasons why we shouldn't use it, to diagnose active TB. The thing that's interesting is that it became positive as the disease got worse, which was something that I would not have expected. I don't know. I think that should be every time on a differential. If you have a foreign-born, or even a U.S.-born who has a lot of the risk factors with fevers and the usual things, the usual pneumonias, the usual things that you work up are negative. TB is a masquerader, so you always need to keep that in your back pocket as, well, could this be TB? And then especially in patients who have who are immunosuppressed, they're at the greatest risk to reactivate. And then when they reactivate, they can be very atypical. Well, I think, are you referring to bovis? That is true. There are certainly cases in the United States of Mycobacterium bovis, which can be acquired through drinking unpasteurized milk. Typically, the clue on that is after it grows, it looks like TB, but it's PZA resistant. but that's not commonly done in Eastern Europe.
And as just a brief intro, I went to undergraduate at the Ohio State University. I then subsequently went to Bowman Gray in Winston-Salem, North Carolina for my residency and internship. And then after that had the opportunity to go to Emory, where I did my fellowship in infectious disease, and also had the opportunity to do the research component at the CDC, and that was just a really delightful experience. Today, I'm going to talk to you a little bit about something different. I just want to provide some acknowledgments provided by not only the folks in employee health, but also from our sources for these diagnostic tests, as well as some slides from the CDC, and a special thanks to the scientific director, Dr. Clark, who provided some essential information to us that I will be revealing here shortly. Let's start off with a little bit something different. How do you check for TB in a cow? And for those of you who were here last year, I shared with you that the reason IGRA tests or interferon gamma release assays were developed was because of this very question, because cows tend to be hairy, and the current way to do it prior to this testing was to place a PPD on the anal ring of a cow. You can imagine the cows were not terribly excited about this practice. And this had a certain amount of hazard associated with sticking a needle in the ass of a cow. So thus, the IGRA was a test that was developed and was the impetus for the quantiferin gold and then subsequently the T-spot. But as we talked about the issues here, we're talking about those that have a low likelihood of tuberculosis and those who have a high likelihood of tuberculosis. Any test in a high prevalence population is going to be better. What we have a real problem with is how do you take the PPD, which we've been using for a long time, and apply it to a low incidence population such as the United States, and it doesn't fare too well. And so it became very important to develop a test such as, again, the IGRA or interferon gamma release assays that would allow us to be able to test and more definitively identify those who appeared to have latent or active tuberculosis. It comes with again, false positives, false negatives, as we've already discussed. And so it cannot be relied on, but it should be a part of the panel of things one does to consider on a case-by-case basis. The converse is true. If the IGRA is positive, you don't necessarily have active tuberculosis, but need to evaluate it in context and then make a decision, does this person really have tuberculosis? That becomes more of an issue when you start to have an equivocal or a low positive result. And really my talk today, having really discussed how the IGRAs came to be and what we did about them last year, today it's really to say, well, how do we interpret these tests and what do we do when the test is indeterminate? And I come to you now with working on 3 years of data from our site where we have now started to test those employees that we're testing who are at risk for tuberculosis, and specifically those who work more than 10 8-hour shifts at Randalia, or those that the guidelines state we have to test, such as food servers, in the dietary department, the laboratory, etc. We know that with the T-spot, that there is a gray zone established at 5 to 7 spots, and so we have some pretty good data for what to do with the T-spot. We don't have great data for quantiferon, and so we've had a number of different people who have looked and produced different studies to help, and so as we changed from PPD to IGRA, we now went from having a handful of people that were positive to like 225 people that were positive. And so we had the change meant that we were now dealing with this enormous number of new positives, many of them that we had never known of before. And some of those people weren't really positive. And we had to struggle with how are we going to deal with this new onslaught of positive tests. And what we did was we looked at this literature and we discussed with experts, and really, to be quite honest, we pilfered what was being done at the Cleveland Clinic because it made the most sense to us. And what they did was they decided to look at grouping of people, and this was based on the work done by Dr. Martyr. And clearly those who are 0.35 and below are negative. Those from 0.35 to 0.7 became our low positives, and 0.7 to 1 became our intermediate positives, and greater than 1 became our high positives. And this became quite useful because it was pretty clear based on the literature that if you were 1.0 or higher, that the chance of you actually having tuberculosis was pretty darn good. It allowed us to take this intermediate group of 0.35 to 1 and divide them with different stratifications based on some of the research that some of the papers that have been published. And that let us be able to tell that the majority of this group on retesting is going to be negative. The majority of this group, or many in this group, will also be negative, but we're going to have a significant increase in the number of positives upon repeat testing. One of the questions that we asked was, well, should we do a different test? If we've done a quantiferon, should we do a PPD? Should we do a T-spot? And in conferring with those experts and reviewing the literature, the answer is pretty clear. Don't do a different test. You need the information that you glean from repeating the same test and then comparing those two values. And so that's become our policy. We will repeat that test within 1 to 3 months of the initial test, and a third test is not generally necessary, and we rarely do that. Instead, if we have somebody who remains in that indeterminate zone, we've already assessed them to see if they have active disease, and they do not. So our game plan is going to be, in the absence of active disease, we'll see what happens next year. And we'll continue to monitor should they develop any signs of active disease and unexplained fever, unexplained weight loss, night sweats lasting more than 2 weeks. Those kinds of things would then trigger us to want to investigate a little further. So people that have TB tests remaining greater than 1 for 2 tests should be considered persistently infected and thus treated. Makes sense. Those then, and again, the T-spot is a lot clearer. That's why I'm focusing a bit on the quantiferon, because that was where we had the most trouble. Those who remained between 0.7 and 1 for 2 tests were monitored at 3 to 6 month intervals by doing the have you had fever, have you had weight loss, have you had night sweats. Those that remained between 0.35 and 0.7 were considered low risk for infection, that should be low risk for infection, and just monitored annually. And then all healthcare workers would be tested according to our surveillance cycle, which again, we had people who've now moved from Randalia up to PRMC exclusively, and those people we've now dropped off our list unless we have some other reason to want to continue to monitor what they do. The issue that we're struggling with today is what to do with the known positive. The surgeon who comes from India or the pulmonologist who comes from China and goes back, perhaps for a lengthy period of time, and then returns back here with either possible re-exposure or and has not taken any kind of treatment. What do we do with that group? And I don't have an answer for you today. Perhaps by next CIDNAC I will, but this is a major area that we struggle with. Well, okay, so let's talk a little bit about the T-spot. You see that we have the nil control or null control. We have then panel A and panel B looking at some different antigens to act as our positive controls, and then we have positive controls as well. So what we're looking in the European, you need greater than 6 spots, but here in the United States, we've decided that 5 to 7 spots is equivocal, greater than 8 is positive, and it's invalid if you have in your test, it should be negative if you have more than 10 spots, or less than 20 spots in what should be your positive. All right, so here's some real life, these are Parkview data. These are Parkview people that have been tested. And so here we have a T-spot test. This is what the report looks like. And it comes in without the little pretty picture. It comes in with this, where the nil test was 2. Okay, so that's not too high. We have a panel count of 4, and the positive control was, in fact, positive, as it should be. So that tells us that we then fit with 4. Okay, so that's 4 negative. That's our 4 or less. That's a negative test. We have this T-spot result where we have, again, 3 in the negative, so that worked out good. We have a total of 5. Well, now we're here in the wobble zone. And our positive control was positive. So in this case, it was reported as negative, but this is truly in our indeterminate or in our wobble zone. And so a person that we're going to have a little more concern, that we're going to want to watch and consider retesting in that 1 to 3 weeks to see how does it change. Here we have a nil that is 0, okay. We have 17, 18, 19 count, and our positive control is positive, so this is clearly a positive test. The reason that I bring this to you is really so that you understand this middle one, okay. A negative is negative, a positive is positive, but what happens when it says negative, but you're in the wobble zone? And that's why I want to raise your awareness so that you can interpret this and say, oh, Dr. Steinecker said, I need to be worried about this fellow. And let's recheck that T-spot and see what it is 1 to 3 months later. Again, you have your negative controls, and then you have your positive controls, and then you have your antigens. Just another picture that obviously didn't show up very well. Thank you, Google. Here we have a nil count of 9, which is almost getting to the point of being too many so that it invalidates the test. And let's just to back up here, if you have more than 10 spots in the nil control, it invalidates the test. So you're coming close, and so you just are asking the question, well, how valid was this test? The positive control was really positive, but here again, you have 33 spots. This is one that I would still let go and just say, yep, this is positive, but I would also be asking some questions. What's the route of acquisition? What's the likelihood they have real TB? What's the exposure? I would just ask a few more questions. In this case, you now have the nil control that is greater than 10, and even though you have positives here and a positive control, you have an invalid nil control, so that's why this test is invalid. So we'll go on to quantiferons next, but does this make sense? Are there any questions about this at this point for the T-spot? Okay, so that's a little more clear than when we look at our quantiferon golds, which is just a little bit harder to test. Now you get your 3 tubes, your nil, your TB antigen, and mitogen, or this should be positive. And what we've really had trouble with, again, after doing thousands and thousands every year of these tests, and doing our Remicade and other patients on immunosuppressants, what we consistently come up as a flaw or a problem is that these tubes are not shaken. And one of the educational points that I need you to be aware of today is that this isn't shaking. This is shaking, okay? So you really have to agitate that tube or it will come out indeterminate and not work. I went ahead and put up what things should be. So so this is a typical test. This is the line printing that we get from the laboratory. The test comes out with pretty much the same things, and it's a little bit more oblique. You get this QGLD1 and so forth. The first is the result. The second is going to be the nil control, which needs to be less than 0.35, which it is. The positive control needs to be greater than 0.5, which it is, but barely. And then you have the result. The third one down will be the result of the patient. And that's the one where, again, 0.35 and below is negative, 0.35 to 0.7 point is our sort of that intermediate risk zone, and then that high but not yet fully positive is at 0.7 to 1, and then the greater than 1. So you can see this is one that's like, well, nope, that's clearly negative. Here we have our nil control, which is fine. Our positive control is strongly positive, and our sample value is downright 0. So that's clearly okay. Now here we have one where it's 0.6 for the nil control. We have our positive control, which is strongly positive, but our sample value falls within that range at 0.82. So since it's higher than 0.7, this is starting to be high enough to make me get a little squiggly here and start to say, ooh, hey, this might be really something I got to worry about, and this is certainly somebody that I'm going to want to call back and get another quantiferon and see what the difference is after a month or so. Another set here, again, here our nil value is negative, like it should be. Our mitogen should be greater than 0.5, and it's not. So this becomes an indeterminate result. And again, the whole issue here is it doesn't look it doesn't look like the test was, that when it was put into the tube, that it was shaken adequately, and that's what we've really traced it back to. The nil value here is again negative. The mitogen again is not high, so the tubes probably were not shaken adequately. And again, the same thing here. We've been spending a lot of time with education trying to make sure that everybody who draws this test knows that it has to be agitated so that we can really get it properly shaken and get an adequate test. Because it's a reasonably expensive test, something in the $40 without factoring in the collection fee and needles and hubs and all that stuff. But that's why we have the plan to repeat the test whenever we start to see this indeterminate. And with that, I'll be happy to answer any questions about interpretation of IGRAs. And I know that we're right around 2:30, so we've got just a little bit of extra time than we did, and we'll perhaps expand the break just a tad. Yes? Is it required to do the chest x-ray if you have a quantiferon that's positive? The quantiferon should not be used in exclusion to diagnose tuberculosis. So you're absolutely right. What our employee health services will do is they'll first decide, do I need to repeat the test, which is almost always yes. And then when they have then 2 positives, then they're going to then obtain the chest x-ray, do the assessment for whether or not it's latent TB or do we have any evidence for active tuberculosis. Whether they return to work or not really depends upon that assessment. Other questions? Just as a show of hands, how many people here at your site are you using an IGRA over PPD? Is that just, so not very many. Are the rest of you still using, for those who are using PPDs? So that looks like pretty much that's everybody else. Is anybody looking to move to an IGRA within the next 12 months? So just 1, okay, or 2. Interesting. If we can be of assistance, please let us know. We're happy to share. For that, I think the next thing is a break. Is that correct? So let's meet back here at 10 till. Would you rather leave a little bit early, or would you rather leave early? Much better than a longer break. Okay, we'll meet back here at quarter till and resume and push through. All right, everybody, thank you so much. I'm sorry to take away from your networking time because I know how valuable that is, but in an effort to just continue to push on through, I'd like to introduce Caitlin Conrad with the Indiana State Department of Health, STD Prevention, and she'll also give a little bit of better description about what it is that she does. Thank you.
Good afternoon, everyone. Am I turned on? Okay, cool. My name is Caitlin Conrad, and as mentioned, I work for the ISDH, so Indiana State Department of Health, in the STD Prevention Program. And my official title is STD Prevention Program Specialist. It's kind of a mouthful, but essentially what I do is I oversee the area where the Indiana HIV outbreak has been occurring in. A little history about myself. I'm a former disease intervention specialist. I used to be based out of Monroe County, and I also worked in Indianapolis, Marion County. And we're going to go ahead and get started. So the things I want to discuss today, just a quick overview of what's exactly going on in southern Indiana with the outbreak, and essentially how we investigate and test people. And then, of course, what can be done about this? What is the future going to look like? And some lessons that we picked up while we were investigating this. So currently in southern Indiana, we identified in January 2015, through routine surveillance, a cluster of cases in Scott County where they typically only have less than 5 new cases a year. So what happened was our local disease intervention specialists notified us of their current investigations going on, and the STD HIV program, we developed contact maps, and we really started diving into what exactly is going on here. And we identified that the cause was of an oral opiate, specifically Opana. And this is the only HIV cluster of its kind, and it's the